in this computer. Okay, so this is a review session for exam 2, the content that would be included in exam 2 and adult till 3. So the content will start with the breast cancer and endometriosis and postmenopausal uterine hemorrhage. So the case study, the first one, it's about the mammogram and patient, a patient who is going to undergo mammogram for suspected a lump in the breast, or which is breast cancer in this case. So the answer to the first question, what age is the mammographic screening recommended for the general population? And I also, if you go back to the Canvas, you'll find also a file, or like a detailed document about the mammogram, the description of the whole procedure, the before and after teaching, and all the details that would entail this testing. So the answer is at age 50 years old. So for women at average risk, screening mammogram is recommended to begin at the age of 50 years. So this patient should have, so this scenario, or patient in this scenario, should have been screened starting at age 40 years because of the very significant family history. So women in the general population at risk of 12% to 14%. So this is like 1 in 9 cases without any family history. So with 2 first-degree relatives, the patient's risk is going to be closer to about 40 to 50%. So it's risk factors, and what makes it more higher percentage in terms of the probability of getting the cancer, the breast cancer, is the having a first-degree relative. So first-degree relatives like siblings, parents.
Professor, are you sharing your screen? Because I can't see the questions.
Okay, let me stop sharing, because earlier I shared maybe with the when I opened the Canvas. Now, can see it? Can you see my screen?
Yes.
Yeah.
All right. So that was the first question about the at age of 50 years old, and I explained why the 40 with the first degree relative. That was the it's becomes more high risk when the first degree relative isn't that patient has one who has been affected by this disease. So the probability percentage of having this disease will go higher. So the second question is about it says with the family history of breast cancer. Now, besides starting screening early, which would be the best, so in terms of prevention or prevented having this breast cancer? So in terms of what would be the best preventive measure to be integrated or have been implemented in the plan of care for this patient, and the answer for this question is going to be the tamoxifen, the medication tamoxifen, and it's also I included that I would have this drug or medication included on my review. I have another set of PowerPoint slides, few slides in terms of I'm going over like the most significant concepts and content from the different areas like in neuro and kidneys and renal disorders, as well as the cancer or breast cancer. So that will be the last slide in the other set of PowerPoint slides, but this one is purely talking about the breast cancer and endometriosis. So the answer is tamoxifen, and because tamoxifen will prevent the breast cancer from occurring in the first place. So these are the SERM, which is selective estrogen receptor modulators, and they are given these selective or these SERM medications like tamoxifen it gives a 50% reduction in the risk of having that disease, the breast cancer disease. So they are used for women with more cases or patients with two first degree relative. So once a patient has been identified having two family or first degree relatives, two of them who have had that disease, so that history requires that we have to implement this kind of patient supposed to take this drug, the tamoxifen. So again, this drug is being prescribed is usually prescribed for patients with two first degree relatives who are at much higher risk of breast cancer than the general population. So why not breast ultrasound? The ultrasound is used when there is a lump that is detected in a younger premenopausal patient, and it's not clear if the lesion is solid or cystic in nature. What about the MRI, the breast MRI? The breast MRI is useful in evaluating firm breasts with unusual architecture, but it's not clear that the MRI is definitely better than the mammogram. So the BRCA, which is the testing, the genetic testing or BRC testing, it doesn't prevent cancer. It's more of predictive or more of diagnostic, and it's associated with only 10%. The BRCA, it's only associated with a 10% of patients with familial breast cancer. But in this patient, in this scenario, this case study of this scenario, we already know that that patient is at high risk of having this breast cancer. In terms of the breast, it is not clear that the BRCA offers that kind of prediction. So the SERM, which is the tamoxifen, the selective estrogen receptor modulators, like tamoxifen, it will stop cancer. So that's the answer for that question. And then next, the next question is which of the following should be done next, given patient has received like certain medications like the estrogen receptor. The report came back as estrogen receptor was positive, the progesterone receptor was positive as well, and there was a test called Sentinel node biopsy. That biopsy taken from the breast lump or tumor, that's to determine. That's usually the Sentinel node biopsy. It's usually taken or done to determine whether the cancer has spread beyond the primary tumor into the lymphatic system. So we can say it's confined just to the tissues in the breast, or it has kind of invaded adjacent or distant, especially here adjacent, kind of especially through the lymphatic system, which is like in terms of here we can call metastasis. In terms of that kind of breast cancer cells has metastasized to either adjacent or distant cells or tissues via that lymphatic system. So it is used most commonly in evaluating breast cancer and melanoma, which is the Sentinel node biopsy. So next, for that patient, we're going to do this test, which is the sentinel node biopsy. So this test is the first. It's very clear that this is the node. This is when they do the sentinel, it's going to be like color like that, and that will be the detected as breast cancer. So the answer to the next question. So then the patient went through other modalities like or has been recommended or supposed to be consulted by surgical team, oncology consultation as well, and lumpectomy to be should be done according to the surgical team recommendations. So when we see lumpectomy means it's the modified breast mastectomy. So which is the eradication of the breast tissues, and now without radiation, because sometimes we go with between we start with the radiation, chemo, radiation, and then they do the surgical. But most of the time they do the surgical procedure and then they do the radiation. So without radiation to the breast, the cancer will reoccur with lumpectomy alone. So that's why we have to do sometimes combination of both modalities in terms of surgical treatment or surgical intervention and radiation as well, and chemo. Depends. So it's very individual in terms of the plan of care. It's not always the same plan for all. It doesn't fit all patients. So sometimes we have to be careful with the hormone testing, the results, and the extent of the tumor, the size and metastasis has occurred or not. So again, it has to be very individualized when it comes to the treatment for breast cancer. So the so breast tumors are tested to see if they are estrogen receptor and or if they are estrogen receptor or progesterone receptor positive. So it depends on, sometimes both are positive. Like in this patient, we have estrogen receptor positive and the progesterone receptor is positive as well. Now if the estrogen receptor, the hormone receptor tests are both prognostic and predictive. In other words, that I'm not asking that you have to be like to specialize in this this kind of area, but at least to know that the receptor, if that's estrogen or progesterone, makes a big difference in the treatment. So the hormone receptor test, negative or positive, it has at least to know that this kind of testing, estrogen receptor test, positive or negative, progesterone receptor test, positive or negative, would, according to that result, it determines and dictates or determines the type of prognosis and prediction of the treatment. So tumors that are like estrogen receptor positive and or progesterone receptor positive, either or, they are slightly slower growing. In terms of the tumor, it will be slower growing, and they have a slightly better prognosis than tumor that are not. So the positive ones are look at more of the positive aspect, kind of compared to the negative one. So when the estrogen receptor ER positive and or the PR, which is progesterone receptor positive, both or either or, now the tumor is going to be slightly slower growing, and the prognosis will be better than the other cases in patients whose estrogen receptor negative or progesterone receptor negative, because not just for the nature of the disease process, but also for the treatment, like tamoxifen, will be more effective. So that's about the hormones and how hormone therapy would the treatment in terms of the hormone therapy, not just testing, but also the therapy, is going to slow or stop the cancer growth. That's where tamoxifen is the most effective treatment to stop the breast cancer. And I also listed other medications that, for review in the other set of PowerPoint slides. The last slide, it, includes all these medications, including which includes the medications for breast cancer. So we have two different scenarios here for treatment. So the early stage of breast cancer, these treatments would include tamoxifen, as I said, tamoxifen and another one medication or class of medications that belong to what is called the aromatase inhibitors, the AIs, aromatase inhibitors, AIs. There are three medications available approved by the FDA, 3 medications. And the other group of people who are patients would be treated. So we have early stage of cancer, of breast cancer, and we have also women, the other patients or women with some metastasis. So breast cancer who has metastasized to other areas or tissues. So metastatic breast cancer, these women would be treated with other like a different set of medications and options, the therapy options that would include one of the medications. I believe one of my students in the clinical group, we have a patient on that medication was megestrol acetate, which is Megace. Megestrol acetate, which is Megace. So this is anti-cancer drug, but the off-label use for that patient, that older adult patient with dysphagia, I believe, and weight loss, significant weight loss, and kind of cachectic. Patient was losing a lot of weight, so to increase, like enhance the appetite, that medication has that's kind of off-label use, but it's an anti-cancer, anti-metabolite, or anti-cancer drug. So it's called megestrol, Megestrol acetate. So that's the generic name. The brand name is called Megace, Megace. So Megace or megestrol acetate, it's one of these drugs similar to the propofol, like in terms of like the color. It's like a milky color, like liquid form. It's like a milk of magnesia, and very close to that kind of liquid form, yellow, yeah, whitish color. So it's the Megace anti-cancer drug, and that would be one of the other 3 medications that are most effective for women with metastasis or metastasized breast cancer case. So, which of the following will lower mortality the most? We would say that the answer is adjuvant chemotherapy. So, because the adjuvant chemotherapy, and you will see the word adjuvant has been also used in other like therapeutic modalities, like in pain medication, pain management. We always talk about adjuvant. So adjuvant chemotherapy is like it's not the main element of the treatment or therapy. So it's got a drug that has been added. So adjuvant chemotherapy provides a definite mortality benefit. So the adjuvant means the chemotherapy that is used to prevent metastasis. That's the better way to to look at the adjuvant chemotherapy. So it's the chemotherapy, the adjuvant, the chemotherapy which is going to be utilized or used to prevent metastasis. So it's not prophylactic because the person already has cancer. So which of the following is the most common adverse effect of aromatase inhibitors, the AI they mentioned earlier? And these medications like Arimidex, the Firmara, the Aromacin, these are the 3 medications that are listed under the AIs, the aromatase inhibitors. And when the most common adverse effect from this drug or from this group or class of medications, AIs, the osteoporosis. The osteoporosis occurs because the aromatase inhibitors estrogen production, it will inhibit the estrogen production with side effects, kind of blocks the receptor of the estrogen receptors. Blocking that would inhibit the estrogen production. So these drugs or AIs or aromatase inhibitors, they will prevent or inhibit the estrogen production with side effects including the bone loss, because the loss of the bone matrix or the density of the bone result in what is called osteopenia and then osteoporosis. The SERMs, the SERMs, which is the selective estrogen receptor modulators, like tamoxifen, they have an agonist effect on the bone, not an agonist, the opposite, and an antagonist effect on the breast tissue. So as we compare between the AIs and the SERMs as two different groups of medications, the aromatase inhibitors like the one I just mentioned earlier, but like the Arimidex or the Fermara or the Aromacin, these are the medications that may predispose patient or put the patient at risk for osteoporosis because they inhibit the estrogen production. However, the SERMs, the SERMs, the estrogen receptor, selective estrogen receptor modulators like tamoxifen, they have an agonist effect on the bone, like a positive effect on the bone, because they have an antagonist effect on the brain, on the breast tissues. And that's why the tamoxifen is a great drug because it's selective estrogen receptor modulator. It's selective and it's specifically going to only affect the estrogen receptors in the brain and the breast cells. So the patient underwent or will undergo the radiation therapy to the breast after the lump is removed surgically. So surgical removal of the lump has been done, and then patient will go for radiation after that, status post surgical removal of the lump. Because of the lesion is more or bigger than 1 centimeter, then the chemotherapy will be administered. So patient will also receive the chemotherapy because the size of that lump was bigger than 1 centimeter. So treatment that would lower the mortality rate in patients with breast cancer will be the surgery, like modified radical mastectomy, MRM, modified radical mastectomy. That will lower the mortality rate in patients and women with breast cancer. So it will be the surgery, like modified resection of the modified radical mastectomy and or lumpectomy with radiation. And also, another aspect of a therapy that will lower the mortality is the use of Herceptin, which is HER2, which is the Herceptin E receptor, type E receptor blocker, the trastuzumab. It's a Zumab family, and you will find that drug at the end of again in the medications that for review for exam 2, and it's an extra HER2 antagonists. It's a medication. It's listed as or a class of medication which is HER2. It's called Herceptin. Herceptin is a brand name. The generic name is the trastuzumab. It's like TRASTUZUMAB. It's the trastuzumab. It says like there are a group of medications that will end like the suffixes Zumab, and we have a few of them, but this is one of them called Herceptin. So that's another drug is going to also be one of the treatment modalities that will lower the mortality rate in patients with breast cancer. Adjuvant chemotherapy also can be listed as one of the treatments that will lower the mortality rate, and the SERMs or aromatase inhibitors. So these are like a list of things that may, or medications and treatments or surgeries or interventions that may lower the mortality rate in patients with or women with breast cancer. So to provide blockade of estrogen in premenopausal women, the Lupron, which is Leuprolide, that and the implant, another drug, that are sometimes given to prevent the need for oophorectomy, which is the surgical resection of the ovaries. But how they do work? They work by B, which is they decrease the release of the LH and the FSH hormone. So they lower the or decrease the release of the and production of the luteinizing hormone and the follicle stimulating hormone from the ovaries. So these medications are what is called gonadotropin releasing hormone, GRH, agonist. So they are GRH agonists. So they will block the FSH and the LH hormone release, and that will prevent their release from the ovaries. Let's take other or look at other questions to understand the content under that breast cancer and endometriosis. So this question, see, let's just read it silent reading and look at the answer, or what do you think the answer would be? I'd like people to think with me and look for the answer. And if you have the answer, let me know, please.
Professor, would the answer be C?
Why do you think C? Yes, it is.
Because like if it block like estrogen release, so I don't.
Yes. So the risk of the endometrial cancer, it will be lowered or decreased by 50% after 1 year of oral contraceptive use. And the protective effect seems to persist after stopping the oral contraceptives. So the incidence of the ovarian cancer in OC or oral contraceptive users, it's about 50% less than that found in non-users. The incidence of the PID, which is the pelvic inflammatory disease, is also decreased by 50% in OC users. In well-controlled studies, there is no increase. That's how they found from evidence-based practice. In the well-controlled, controlled studies, there is no increase in the risk of having a child with a major malformation or cardiac malformation or limb abnormality. The ectopic pregnancy, the risk of that ectopic pregnancy is also reduced by 90%, perhaps because the risk of any pregnancy approaches zero when the OC, right, when the oral contraceptive is usually taken correctly and appropriately according to the prescription. Number 2. And I'm pretty sure that you know what is G3P3, right, from the OB course.
Yes.
Okay, good. So what do you think? So do you think that this patient has, or this woman has lost any of her pregnancies, or all three were ended with having a baby?
I mean, she has 3 pregnancy and 3 deaths.
Right. Yeah, gravida 3, para 3. Yeah. Okay. So what do you think the answer is? Conservative measures have failed. Which of the following medications is most likely to bring relief?
Can it be number 2?
Tamoxifen. Yep. So yes, breast discomfort is a problem that is premenstrually for many women. So premenstrually for many women, that's known discomfort. So the simple palliative measures include the administration of like vitamin E, 600 units daily, limiting the methylxanthines by eliminating the coffee and other caffeine-containing substances. Um, uh, Even though we didn't know or understand the mechanism of action well, it's not well understood in this case, but it has been shown to um, decrease the frequency of this discomfort by having taking that vitamin E about like 600 units daily and the limiting the methylxanthines like the coffee. The danazole, which is it's about 200 to 400 milligrams daily. It's more effective, often will be more effective in relieving the pain. But again, we said that these measures have failed. So the Clomid, which is a Clomid, which is may have a estrogen side effect, or estrogen, like estrogenic side effect, has to do with estrogen, and that would increase the breast pain. So many women who receive or receiving the progesterone, they note that they experience this discomfort or breast discomfort that will be secondary to the fluid retention. But here we have no evidence that the diuretics, such as like hydrochlorothiazide, would relieve that breast pain. So, so the answer was B. So we have here also a 55-year-old woman who has a blood discharge from left breast, and the mammogram discloses or revealed that a cluster of micro calcifications, it's about size about 3 centimeters beneath her left nipple. So which of the following is the best next step in the evaluation or evaluating her medical condition?
Is it biopsy?
Yes. So the image guided, and it has to be like image guided biopsy, percutaneous biopsy, that is preferred because of the fine needle biopsy has about 20% false negative rate. So both the bloody nipple discharge and the microcalcifications are indicators of a breast biopsy, although there are benign appearing radiographic calcifications. The clusters of the calcifications are associated with about 25% chance of having cancer. So the cytology, it's a screening tool. And in the presence of significant risk factors for cancer, a tissue diagnosis is mandatory. It has to be done. Tissue diagnosis should be done. So the imaging studies are also screening tools with a false negative and false positive rate. So you aren't kind of, when you do these imaging tests or studies, there's always a room for a error. So positive, false positive or false negative rate, it's there. So it's not accurate, making such these studies inappropriate for diagnoses. So that's why the guided or image guided percutaneous biopsy, that was the correct answer. Next question, which is the following is the principal advantage of the fine needle aspiration, FNA. That's abbreviated as FNA or acronym for fine needle aspiration of the breast mass. So the advantage is B. or the final aspiration of breast mass, or that it can distinguish between the cystic, if that's just a cyst, and if it's, on the other side, it's solid lesion. Kind of differentiate between a cystic or solid lesion or a tumor, and it reduces the number of open breast biopsies when it is positive for cancer. However, the negative needle biopsy, it's a non-diagnostic. It's not assuring, and the open biopsy is still necessary. So the fine needle biopsy, it doesn't differentiate between non-invasive and the invasive cancer, nor it does it delineate or delineate the extent or provide more details about the extent of the in situ disease. So most surgeons or breast surgeons will not perform definitive surgery like mastectomy or lumpectomy with lymph node dissection without histologic confirmation of cancer. They have to do the histologic confirmation of the cancer, and then we'll go further to the next step, which is more of the surgical intervention, if that's mastectomy or lumpectomy. They will do like a core needle biopsy, surgical biopsy, or frozen section at the time of the lumpectomy. Sometimes I worked in the OR for 2 years, and we used to do these kind of be involved in these surgeries, and used to see that frozen section. They get the biopsy, and the surgeon will cover, the surgical, site, and wait for the result of that biopsy. It's called frozen section, and that will be done at the time during surgery. So 10, 15 waiting time while waiting for the frozen section result of the frozen section, and then they will proceed based on the results. They will continue with radical mastectomy, or less aggressive surgery might be recommended based on the results of the frozen section. So these are kind of so the answer was B. Next question.
Is it E?
Okay, what do you think E is the correct answer?
First degree.
You remember the number one risk factor for all different types of cancer? All different types of cancer, the first risk factor and the top of all risk factors is always going to be age. Age, because of the genetic hits that we experience on a daily basis. So the factor associated with the greatest lifetime risk for developing breast cancer is age of the woman. So heredity or genetic predisposition, it accounts for the 5 to 10% of all breast cancers. That's called hereditary breast cancers. They account for about 5 to 10% of all breast cancers, and give the woman a relative risk of approximately 2. So the relative risk is 4 with 2 first-degree relatives. That's, when we look at the or rate the risk in terms of 1, 2, 3, 4. That's when it comes that the hereditary breast cancers, they account for 5 to 10% of all breast cancers, and give the woman of the first relative risk of approximately about 2, and the relative risk is 4 when that woman has, or patient has, 2 first-degree relatives. That's a higher risk. So increased lifetime estrogen exposure also is a minor, but it's a factor, but it's a minor risk factor for breast cancer in terms of the lifetime exposure to estrogen. Obesity, early menarche, or late menopause, and low parity, they are associated with an increased lifetime estrogen exposure, and they are minor risk factors for breast cancer. So the prevalence of the breast cancer increased from 30 to about like 10,000 women yearly. And I'm sorry, from 30 per 10,000 to about like 38 per 10,000. And so the answer was age. Which of the following is the most common type of breast cancer? Most common type is the invasive one, which is the infiltrative one. Infiltrative, which is the D type. It's the infiltrating invasive ductal, which is invasive, ductal carcinoma. This one accounts for about 65 up to 80% of all breast cancers or carcinomas. So infiltrating lobar carcinoma accounts for about 10 to 14%, and the all others about 5% or less. So D, the invasive one, which is infiltrating ductal carcinoma, which accounts for 65 to 80% of all different types of breast cancers. 7, which is the following, is the best predictor of survival after appropriate treatment of breast cancer. And survival, predictor of survival after appropriate treatment has been implemented or done or administered. Most of the time, it's the tumor size, right? It's the tumor size, so the size of the tumor. So the answer should be
Hey, Dr. Mikky.
right. So in women with a primary tumor of 1 up to 1.5 centimeter or less, the recurrence risk is approximately about 15%. So primarily because the likelihood of complete excision or removal, like surgical removal, is greatest. So the smaller, the better. So that's going to be much easier for the surgeon to remove and less predictive in terms of metastasis and other problems. So again, in women with a primary tumor of 1 up to 1.5 centimeter or less, the recurrence risk is approximately 15%, primarily because the likelihood of complete excision is greatest. So we kind of assure that when the surgeon is going to remove the tumor, will be completely removed with all adjacent affected or like cancerous cells, and much less of a future risk of having recurrence breast cancer. Okay, and 39-year-old woman known to have fibrocystic disease of the breast, complains of persistent fullness and pain in both breasts, which the following drugs will be most effective in relieving her symptoms.
Is it E?
Hydrochlorothiazide provide unpredictable relief of symptoms. It's the diuretic. It's not going to be effective like danazol. Danazol in oral doses
Professor,
of,
what
yeah,
question is that?
Wait, I'm looking at number 8.
Yeah, it says a 35-year-old woman.
it's not
It doesn't have
flipping.
anything
It's
about
not moving.
medication in there.
It's not moving. The 39-year-old.
Yeah, Professor, right there, number 8. That's where we were.
Right. I think, yeah, we didn't answer this question.
Yeah, she was saying E.
1 second. Sorry.
Dr. Mikky, I can hear
Yes.
you.
Yeah, I believe I answered that question, right? So we are now 35-year-old. Okay, sorry. Yes. So for the answer is final aspiration. So so that's the patient who is 35-year-old woman. So the breast cancer is rare in women younger than 35 years old. And the approximate incidence of breast cancer and pregnancy, it will be like 1 in 3,000 deliveries. So survival rates from breast cancer and pregnancy are less than in non-pregnant women of comparable age. So this is due to delayed diagnoses and not a biological effect of pregnancy. So the pregnant woman, when matched for disease stage, I will have identical survival rates as non-pregnant women. So despite the pregnancy, the presence of a dominant mass require histologic evaluation. And next question is 1 centimeter carcinoma breast is diagnosed by excisional biopsy in a 36-year-old woman at 15 weeks gestation. Axillary nodes are negative, which is the following is the best management for this patient. So this patient, if the surgeon is going to look at the case and decide or determine what type of, best modality or intervention to be implemented for this case and be therapeutic and with good prognoses, they will go with modified radical mastectomy at the time of diagnosis. So the breast cancers in young women tend to be aggressive tumors and estrogen receptor negative. So young women with the estrogen receptor negative. Remember, we talk about the hormone and the receptors, negative and positive. So the breast cancer in young women tend to be aggressive tumors and estrogen receptor negative, both of which would worsen the diagnosis. So age and the receptor negative. So for this reason, the cancer should be treated surgically, usually modified radical mastectomy to minimize the need for the adjuvant, because if they do it at this time of the diagnosis, they will limit or they will no need for chemo or radiation after that. So they can minimize the need for the adjuvant radiation or chemotherapy with wide local excision or of a lumpectomy. When they do a complete modified radical mastectomy, they remove the whole, everything, and they are patient will, no need for adjuvant radiation or chemotherapy after that. So there is a little convincing evidence that the termination of pregnancy will improve diagnoses. However, the answer was E. Okay, so any questions pertains to that breast cancer? And I'm going to also review some other stuff from breast cancer. Any questions? Okay, so same thing when you can go to also Canvas and to modules, and it will be the top, like the first tab, exam 2 review, another few, like set of few PowerPoint slides. I'm going to follow them, use them when I review the content. Okay, I believe you can. Everyone can see my slides, the exam review.
Yes.
Yeah.
All right. So this is the these are how many slides do we have? About 16 slides. Yeah, I'm going to use them um, to go over the content and just highlight the most important concepts. So let's
Professor,
try.
that's shared with us. That's shared with us on the blackboard, on the canvas.
Yes, it's right. If you go to Canvas under modules, and to the top on the first tab, modules first tab, it says exam to review, and these
Yeah.
are the 16 slides. So one more time about the breast cancer, you would review, like go over that stuff, and then when we say mammogram, regular mammogram can help detect the breast cancer at early stage. The FNA, which is fine needle biopsy, it's done in the outpatient setting. Usually, you know, um, doctors or nurse practitioners, like clinic or so. It's can be done in outpatient setting, and that's for the FNA. And there is also available within like 24 to 48 hours, maybe guided by ultrasound, but not by the mammogram. So because of the immobility of the breast lump suggests cancer, so further testing will be done for a patient who has a negative result of the FNA. The Herceptin, the medication I mentioned earlier about the Herceptin, which is the trastuzumab, it can lead to one of the side effects of this drug, the Herceptin, the H2ER blocker or antagonist. It can lead to ventricular dysfunction. So it has kind of cardiac side effect. So that patient will be educated about the side effects and to self-monitor the patient for like symptoms of heart failure, patients on these medications. The tamoxifen, one of the most commonly, like, all women who take or on tamoxifen, is they always complain of the hot flashes and the changes in visual acuity as two main side effects of this drug. Tamoxifen, two major side effects are hot flashes and changes or alteration in visual acuity. So changes in the visual acuity and hot flashes for tamoxifen, cardiac with Herceptin. Very important nursing care when you go over that content for breast cancer, mastectomy, and post-op. Post-op, it's very significant, I would say, content here, concepts here, post-op, post-mastectomy. So let's see, I think I have a slide that talks about that. Yeah. So post-mastectomy, the patient is at risk for lymphedema. And this is one of the questions always repeatedly coming in, like you will see it and expected in board exams, my exams, because that's the most challenging and it's preventable, by the way, to a high extent, which is the lymphedema. Lymphedema. So the patient will be at risk post mastectomy because we are going to remove the tissue with the lymph nodes, so the whole lymphatic system, the drainage system that will prevent these kind of fluid retention and retention of the fluid is gone. So the patient will be at risk for fluid retention of the upper aspect of the body. So the patient will be at risk for lymphedema and infection. So that's why you will see a note like patients with renal failure with an AV fistula. You will see a note by the patient's bed or the head of the bed saying that no venipuncture, no blood pressures from that affected side. Same thing here. Patients, post like right side mastectomy, then you will imagine the same thing or expect the same thing to be done. No venipuncture, no blood pressure, no application of any type of pressure on the affected side. Also, the patient should be taught to use the PCA, like patient controlled analgesia machine or pump or device as needed for pain control. That's after the mastectomy. We will teach the patient how to use the PCA pump and how to push, when to push, or kind of like, teach them about all that PCA and the details entails the PCA machine or pump. The nurse will also allow the patient to examine the incision and participate in care when the patient feels ready for discharge. About the prostheses, the permanent breast prostheses are usually obtained about like 6 weeks after surgery. If there is any prostheses to be considered, then that will be done like about 6 weeks after surgery. That's the permanent breast prostheses. Now for the kidneys know about the stages of AKI and the manifestations, electrolyte imbalances associated with the AKI disorder. Now the CKD and ESRD, other than what I have here on the slide, but also I'm going to highlight a few things. Like the treatment of chronic patients with ESRD and on hemodialysis. They will be, I'm sure that, I mentioned that in class in terms of that the EPO, the erythropoietin hormone will be synthetic EPO hormone will be administered to the patient, but I'm going to adopt these two numbers. If I said like 10, 30, I found that most practitioners and most even textbooks now go up to like 12, hemoglobin of 12 and hematocrit 30. So in the exam, patients with ESRD on hemodialysis, on Procrit, Epigen, or any brand name of an EPO hormone synthetically given IV or sub-Q, that we have to go by or be in compliant with these two numbers. Patients HNH, hemoglobin hematocrit, 1230 or above, hold EPO for that patient, should not be given. And I'm sure that you know why. Can you provide the rationale why should be held when hemoglobin is 12 or higher and or hematocrit 30 or higher?
High blood pressure.
Right, high blood pressure and stroke. Yeah. The second concept here, which is phosphate binders, make sure that the patient on silvamir, which is hydrochloride, which is like Renal, Renvilla. There are other brand names that, for this silvamir generic name. These medications will reduce the absorption of phosphorus from the intestines. So it will elevate the serum calcium. When you lower the phosphorus, automatically calcium level will rise or go up. So it will lower the phosphorus, and at the same time it will augment or increase the serum calcium level. So phosphorus is elevated in chronic renal failure because the kidneys are unable to excrete phosphorus. And remember also, any form of milk and magnesia or any medication that has any type of phosphorus should be, we have to find an alternative medication to that one, and not given the milk of magnesia should not be given to the patient. Now complications would include this equilibrium syndrome, in which that the patient will have all these symptoms, right? So then we talk about in class about this syndrome and the preventive measures, and so the other complications of so what about the peritoneal dialysis? Peritoneal dialysis, complications of PD, peritoneal dialysis, infections. Yeah, bleeding, infections, infections. You'll find the cloudy. I'm sorry. Perforation too, right? So infections like peritonitis, we have to go over the manifestations of peritonitis. if there is like a brownish effluent, the effluent, which is the dialysate, we drain, dwell in the abdomen, and then it will, infuse, dwell, stay there on the abdomen, and then will drain, will be drained. So we have infuse, dwell, drain, the three phases of the peritoneal dialysis. So if this effluent, the dialysate, has been infused in the abdomen and then drained, we found that it's brownish in the bag, in the collecting bag. It's a brownish effluent. That's a sign of the intestinal obstruction. Perforation. And or when it's cloudy or opaque, then it's a sign of infection. Bloody or reddish color, that's bloody, that's blood, the hemorrhage. So read about these three different scenarios and how to be identified and how to be, managed. Read about also the protein intake while on hemodialysis versus peritoneal dialysis. Protein intake and how many milligrams should be given to a patient on hemodialysis versus peritoneal dialysis. So although the peritoneal dialysis is slower than hemodialysis, it doesn't require a specialty trained registered nurse for that, because we know that patients on peritoneal dialysis, they can handle that and independent, like in their own at home setting. They have their own machine. They will hook in the sleep time, and they will have it running while during sleep. So it's kind of skill that can be taught to and educated or taught to the patients. What would be other side effects or risk factors for kidney failure? We went over the contrast media, the medications. What are certain medications that can be hepatotoxic? Sorry, renotoxic. Sorry, renotoxic. So yeah, vancomycin, NSAIDs, yes. They can gentamicin, amikacin, which is the aminoglycosides, and the right, the NSAIDs, yeah, because the NSAIDs we said, and the contrast media also, right? The contrast media. So the NSAIDs, because they reduce the blood flow to the kidneys, so they will lower the renal blood flow. That's why. But when we say the NSAIDs, it's usually we meant the prolonged use of NSAIDs that can lead to kidney damage. Now, hyperkalemia, it's a huge, I think, content pertains to the kidney failure, and then patients on dialysis, they should not eat food that is high in potassium or high in phosphorus. And we need to, I posted also on Canvas, one of the patients, scenarios, it's a real patient, but it includes all the different types of food that is high in phosphorus, high in potassium, and a kind of teaching kind of model to a patient with end-stage disease on hemodialysis. So the hyperkalemia, that's a common complication of in patients with ESRD. It's life-threatening if immediate action wasn't taken to resolve it or reverse the hyperkalemia.
Didn't you say it depends on the level of potassium in the body? That's when you give the treatment.
You can also use dialysis if it's really severe.
If it's extremely high, yeah, if you do dialysis for a patient who has no history of even kidney disease. And the hemodialysis can be also one of the modalities to treat patients with extremely high numbers of hyperkalemia, potassium levels.
In glucose, Dr. Mikky?
I'm sorry. Yeah, you can. Yeah. And same, also I have one of the like 1 or 2 pages of a treatment for hyperkalemia on Canvas. The 3 different levels of hyperkalemia, like mild, moderate, severe, and hyperkalemia when you give like cakesalate, right? The lowest level, mild, then moderate you would give. So mild, you give cakesalate. Moderate, you will give the
Insulin and glucose.
insulin glucose, and then when it's higher, you give the calcium gluconate or hemodialysis. So read about that these 3 levels and how would you treat each level with different modality of hyperkalemia with different modality. The osteoporosis tend to be also one of the other complications. So we have osteoporosis. So and sorry, yeah, calcium, because there is this kind of significant link between hypocalcemia, because patients with ESRD, they tend to have hypocalcemia. And then with this hypocalcemia, they will eventually have a increased PTH hormone and which is a hyperparathyroidism. And so the ESRD and osteoporosis, because of that hypocalcemia problem. Now, the osteoporosis would result, so treatment for that, patient will be on Fosamax, which is the alendronate, which is a biphosphonate medication. If you recall from Adult Health 2, we went over this. It's one of the best medications to be given on a weekly basis, once a week, for a patient with, to prevent or to treat osteoporosis. So it should be administered on empty stomach with a full glass of water to promote absorption of the medication. Early morning, patient should remain upright position for at least 30 minutes to prevent regurgitation into the esophagus, and it will prevent esophageal lesions or cancer. So these are recommendations for the Fosamax. And read about the food that is high in phosphorus, because the kidneys failure, it will result in hyperphosphatemia. So the client with ESRD on hemodialysis, because of kidneys unable to handle the phosphorus, so they have to restrict phosphorus containing foods like beans, peas, nuts, peanut, legumes. It's high in phosphorus. It should be restricted. Pericarditis, it's one of the common complications or complications pertains to the chronic kidney disease. So we are going to look for manifestations that would include of pericarditis, chest pain, the increased pulse rate, increased heart rate. The patient would have a shortness of breath. Patients would have so treatment. So read about the pericarditis as a complication or pericarditis in patients with chronic kidney disease. And the lastly, which in renal would be the manifestations of renal transplant rejection. So when the patient experiences the transplant rejection of the kidneys, what are some of these manifestations? Like urine output, temperature, and others. So read about these things. Yes, one of them. Yeah.
Oliguria.
Oliguria, another one. Yeah. Okay, so Okay, the last system will be the Neuro, which is the longest one. So I need about 10 minutes break. What about if I just leave my yeah, I'll be in Zoom. I will just block the mute myself. I'll be back in 10 minutes, okay?
Okay.
Okay.
You can chat if you want together.
Okay.
What up, my homies?
All right, I'm back. Okay, so Parkinson's disease. I'm going just to highlight, give you some bullets and few things pertains to each one of these neurological disorders. Like for example, Parkinson's disease, read about the pathophysiology and so on until you get so that will be for the disease process, and I think most of the like pathophysiology and medications we covered that in platform, but here you need also to go over like nursing care of patients with Parkinson's disease, and especially like daily exercises and the ADLs, medications like Sinemet, levodopa, carbidopa medication, and the supposed to lower the symptoms like the patients with mask-like face, drooling, excessive saliva, and all of that. That has to to treat all these symptoms. A rigidity of the muscles also should be reversed with this medication. And swallowing problems. So one of the so in terms of patient safety here with Parkinson's disease, about the swallowing. So difficult swallowing requires that we have to assess for patient swallowing ability, and then to recommend the best strategy in terms of the intervention. If that has to be, sometimes patient unable to take the thin liquids, and we have to do or make it thickened liquids. Others, we have to give them finger foods. Other, have to be taken so based on the recommendations of usually we go by the dietitian's recommendations, registered dietitian, the RD's recommendations, whatever they recommend, whatever they put some type of suggestion guidelines, and then we are going to follow that. So because in general, chewing and swallowing, it can be problematic in these patients. So we have to give them small, frequent meals, supplement that, with some of with nutritional needs, but at least just think about swallowing and chewing and swallowing issue and how we're going to prevent the aspiration. And at the same time, patients should meet their nutritional requirement, a daily requirement, as recommended by the RDs, the registered dietitian. So that's one concept. So medications, so Parkinson's in terms of pathophysiology, medications, like especially the Sinemet, swallowing issue, activity level. Next is epilepsy. So when the client experiences what is called a tonic-clonic seizures, patient will be in a state of deep relaxation and breathing quietly. Now, during this period, we had to be patient may become unconscious, completely unconscious, or awaking gradually, getting back, or become more semi and then conscious. But if often but the patient will be most of the time also afterwards will be confused, disoriented, fatigue, generalized weakness. They are completely tired, and they go to sleep for sometimes hours, even a whole day, or for until the next day, sleeping. That's from the overactivity or from the overuse of the muscles in terms of the contraction, relaxation. That kind of creates a lot of become patients muscles become fatigued, and patient may go and sleep 4 hours and sometimes until the next day. So and patient most of the time when they have the grand mal seizures, they are amnesic. In other words, they have amnesia and they don't recall what happens with them, what you have experienced, and they have no clue what that happened or occurred to the patient. So they have amnesia in regard to the seizure for the grand mal seizures. Now, status epilepticus, it's like status asthmaticus. Status epilepticus, which is a state of continuous patient who had experienced more than one seizure activity or epilepsy or seizure activity within the 30 minutes, one or more than one activity. So, or it's the same activity or the same seizure activity has continued for a while, for like 10, 15, 20 minutes. So it's a state of continuous seizure activity or a condition in which seizures recur in rapid succession without return to consciousness before seizures. So either it's one attack continues or one after the other, like frequent attacks in succession without any interruption. So that's the most serious complication of epilepsy. That's the status epilepticus, and it's a neurologic emergency. So status epilepticus can occur due to any type of seizure. Any type of seizure can develop this type of status epilepticus. Sometimes they refer to like risk factors that may contribute to this, like stress, infection, other diseases, and other factors. So during repeated seizures, the brain, this is the most dangerous thing about the status epilepticus, is that during this status epilepticus, that the patient will experience repeated seizures. So the brain uses more energy and there is no supply. So that's kind of high demand and less supply. And we know that the brain uses continuously, the only tissue that continuously utilizing the glucose is the brain cells. Continuously use glucose, but they don't store it. There is no storage like other cells or other muscles and other body tissues, but the brain is the only cell or organ that consists of tissues and cells that do not store glucose and needs continuous source of glucose. Now, the next slide talks about compares between the bacterial versus the viral meningitis. And I believe that I went over, over this in class, and we have few scenarios about the protein level and the glucose level. We said that the theory that kind of provide the rationale behind why would that patient with bacterial meningitis will have a decreased CSF glucose level is because they believe, it's kind of, theorists believe or scientists believe that because bacteria live on glucose, that explains why patients with bacterial meningitis, the CSF fluid tend to have low glucose levels compared to the viral meningitis. But you will find also extremely high protein level in viral meningitis compared to, and also protein level will be higher in both, but more in bacterial meningitis more than viral meningitis. White blood cells over 1,000 and bacterial, 25 up to 500 in viral. So pretty much, I would say that what determines or at least it's not it's confirmatory for aside from the manifestations, but we use the CSF fluid analysis as a confirmatory diagnosis for meningitis in addition to the patient's clinical manifestations. But the cloudy, the low glucose levels, high protein, that kind of confirms that this is a bacterial illness, not viral meningitis. And spinal cord injuries, the positioning post-trauma, like after on the scene or post, like whenever you get the patient or receive the patient after the injury. It depends on when the onset has occurred, but at least log roll technique when transferring the patients with suspected spinal trauma or spinal cord injury. So that's that how would you transport the client with a suspected cervical or cervical and other levels of neurological injury. Safe transfer, status post suspected spinal cord injury, how would you transfer them and the positioning to prevent the further trauma and injury to the spinal cord. So that technique is very important to be used with suspected high level spinal cord injuries like cervical or thoracic levels. And also read about the spinal shock and neurogenic shock and the difference between them. Precipitating factors also for the dysreflexia, the phenomena of dysreflexia or earflexia or autonomic dysreflexia, and what factors that may precipitate this complication. This is life-threatening, this complication, and the precipitating factors for this dysreflexia. Too much of urine, like full bladder, like we have to palpate the bladder to make sure it's not full, like which is looking for signs of urinary retention. The patient doesn't have like patient is currently on some type of stool softener or sometimes of a medication to prevent constipation. So that will be also to assess for the fecal impaction or constipation, because these are the two main causes of or predisposing factors to the dysreflexia. So if the patient has a urine catheter, like indwelling catheter, then to check for the catheter kinks or catheter occlusion or catheter blockages, because that can lead to the urinary retention as well, and then eventually to dysreflexia. The hydralazine is the anti-hypertensive drug that is very effective for the hyperreflexia, dysreflexia. If that's a 50 or 100 milligrams or 150, like 3 tablets or 50, but usually it's given to a patient with dysreflexia. And also read on Canvas, I did post also a separate document or like a file, kind of like a few pages for the treatment of patients with dysreflexia once been identified as having this complication. What would be the best, like positioning and medications and so forth. So the baclofen, which is the Larasil, that's a muscle relaxant, and that's usually given for different types of cases or scenarios of disorders, and this in the neuro or with neuro disorders, if that's the Parkinson's or so. The main indication for this would be is that it's a muscle relaxant. So it's good for any neurologic disease or disorder that which entails or includes the muscle contraction or spasticity or the rigidity of the muscle. So the manifestations of loss of sensory and or motor function in spinal cord injuries, that's due to the compression on the spinal cord. And remember that also we recommend the use of methylprednisolone or steroid or anti-inflammatory drug to prevent the secondary injury and the more or lessen the pressure on the spinal cord within the 24 to 48 hours post spinal cord injury, because that's when the time that's the time of the inflammation be heightened, and we try to attempt to lessen and to decrease that inflammation around the spinal cord. So the baclofen Larasil is a muscle relaxant, and the adverse effects of Larasil baclofen include the following: exaggerated spasticity. We know that this drug is usually prescribed, given, administered to patients with rigid muscles or spastic muscle, but it's like an over like the drug toxicity or a drug overdose. That's when the patient will exhibit these adverse effects, like exaggerated, like spasticity, like muscle becomes even more spastic, or the muscle becomes more rigid instead of like resolving the conflict. The problem, it becomes even worse. Or tinnitus, ringing the whirling or ringing in the ear. Tinnitus also is known as one of the common side effects or adverse effects of baclofen Larasil. MS. it's so again, we will read about the etiology, manifestations, pathophysiology, manifestations, and the certain and specific, like there are very short list of medications for the MS, and we went over this in class. We said we have the A, right? We have the ABC drug, the ABC classification or drugs. Now, this is a more of a chronic, progressive, chronic neurological disorder in which that there is a times of the patient will have the exacerbation and at other times will have the recession. Oh, I'm sorry, remission. So exacerbation, remission kind of alternate between exacerbation and remission state. So the what would precipitate the exacerbation of the multiple sclerosis, there are a list of factors. I would highlight few things like excessive exertion, so fatigue, overworking, overload in terms of like of physical overload or excessive exertion, temperature like overheating, infections. Three major like class or groups of factors that may that are known as stressor and other stressors, sorry, and other stressors that are known to. So we have stressors, infections, excessive exertion. We have also the overheating. All these like four different areas, the four different like factors that may precipitate the exacerbation of the multiple sclerosis, the MS. So part of the treatment, which is a long-term treatment, it's a progressive disease. So clients should be encouraged to live as independently and normally as possible. So because they have, we should have a plan for them in terms of like to reduce fatigue, conserve energy. So we will have a plan for them, especially to be developed to reduce fatigue and conserve energy, and to maximize and enhance the independence and autonomy to high extent, because over time patients are going to lose kind of control and over their disease. So we have to kind of maximize that and be part of our plan to give them more autonomy and independence in terms of things that they can do, like ADLs, plus that they're all self-management of the chronic disease as well. ALS, and I think not much of what we have said in class, because we covered that in more details in terms of the life expectancy and respiratory problems. They usually tend to die from the respiratory failure. It affects the motor and not the sensory. So cognitively, they are intact. They usually, right? So that's what we said in class. And GBS, the Guillain-Barré syndrome, highlighting other than the etiology and manifestations, diagnoses, and interventions, but the most significant aspect of the treatment modality is going to be the plasmapheresis. And complications of plasmapheresis would be that fluid loss. We have to make sure that patient does not exhibit any signs and symptoms of hypovolemia, because remember that this machine is going to be pulling all that serum, which is blood, and bring it back. But at the same time, you have to give the patients that are going to pull all the serum or the plasma, because the plasma includes all these antibodies, and the antibodies that believe that they attack, right, the nerves or nervous system. So then the patient developed this paralysis with ascending form or ascending nature from down below up. So the plasma is going to filter all these antibodies from the plasma, and so we're going to get all the plasma out and then back with some. So in other words, that we're going to pull the plasma out and give the patient fluid. So make sure that the patient has fluid replacement, enough, like sufficient fluid replacement, and does not develop the hypovolemia. There is no specific risk factors for the GBS, but it believed that patients with acute history, history of acute illness, like viral infection. That's why they found pretty much most of cases of GBS, they tend to have a viral infection, like upper respiratory infection, and then they, develop the GBS. They have received the vaccination and then like 1 to 3 weeks prior, and then they develop the GBS. Or they have some type of trauma, like especially like neurological trauma, or some type of surgery, but these are all risk factors. But they found that, these patients with a history of acute illness, trauma, surgery, or immunization 1 to 3 weeks before the onset of neurological symptoms, that's the most common risk factors for GBS. And we talk about the plasmapheresis and the risk of hypovolemia. So we have to monitor the patient because of the risk of hypovolemia. We have to monitor the patient for the fluid status, intake and output, patient's vital signs like not hypotensive or tachycardiac, and to administer the fluid replacement as indicated. Now the MG, I believe the most important concept under the MG or myasthenia gravis, which is the differentiation between the myasthenia crisis and cholinergic crisis. And I believe that, I went over in class and we spent a good amount of time going over this and the Tinsilon test. Do you have any question about this slide? I mean the MG and the Tinsilon test. If you're still confused, like, unsure about something, but the difference between myasthenia crisis and cholinergic crisis, I think we spent a good amount of time in class going over this and the Tinsilon test. What would be the potential adverse effect of the cholinesterase inhibitors? Because the medications to treat the myasthenia gravis, like prostigmine or pyridostigmine, that's cholinesterase inhibitors like CHEI. So it's a drug to treat MG cases because they have problem with, ptosis, they have swallowing problem, they have energy issue with like becoming fatigued. So the potential adverse effect of the medication for MG, which is pyridostigmine, which is again the class of the pyridostigmine belong to a class of medication called cholinesterase inhibitors. What do you think some of these adverse effects? In other words, that it's as if the patient is going to develop when they are taking
cholinergic effect.
Mouth and
if they
Is
are
that
going
cholinergic?
if they're going to take too much of this drug, like overdose, they tend to go towards, developing the cholinergic or myasthenic crises.
Cholinergic.
Cholinergic crises. And what would you give them? First of all, before atropine, before you give atropine, patient will be presented with excessive saliva or dry
Excessive saliva.
Excessive saliva, yeah.
Yes. So they have excessive saliva, and then we will give them the atropine as an antidote for the cholinergic crises. Sudden increase in weakness and the ability to clear secretions, which is like over secretions, unable to even to swallow them. They will have like a drooling and unable to even to control the saliva. They have breathing also difficulties, and that should indicate that they are experiencing cholinergic crises and not myasthenic crises. Because myasthenic crisis means that they have stopped or haven't taken the drug for a while or for some time. So what about if you found that they have developed, because you will do the Tinsilon test to find out, right? Because you cannot tell it purely like clearly from manifestations. You can tell, you have some idea if that's cholinergic versus like myasthenic, but there is a lot of similarities between these two crises. But what would confirm that this is myasthenic or cholinergic crises? Tensilon, which is again a drug also for the MG, but we cannot use it for as a treatment because it's a ultra short drug. It's within 30 to 60 seconds after injection of tensilon. Most patients will show marked improvement of the muscles, which will last only 4 to 5 minutes. In other words, that you are going to give the drug every 5 minutes. We'll give the patient, right, a dose, which doesn't make sense, right? So we cannot just give tensilon every 5 minutes. It's a medication for that disease, but it's ultra short medication, so it's good for testing, not for treatment. And once you have determined that patient's symptoms have improved, then it's cholinergic crises. It's the myasthenic crises, and then you will treat patient accordingly. So both is considered to be a life-threatening condition, which requires an immediate medical attention. Prostigmine or pyridostigmine, it will promote muscle function in patients with myasthenic crises. Atropine will be given to patient with cholinergic crises. So it's like, what's the antidote for cholinergic crisis will be atropine, which is anticholinergic, right? And then the myasthenic crisis, the antidote for that would be the prostigmine or pyridostigmine, which is the cholinergic cholinesterase inhibitor with HCHEI. And the last two conditions and same thing with with the before we get to the trigeminal neuralgia, but the swallowing and the difficulty chewing food and swallowing the food. It's about the skeletal muscle weakness, which will also be part of the disease process in patients with MG, as well as in patients with Parkinson's and other neurological disorders. So here, also clients who would develop this MG, myasthenia gravis, they are at risk for aspiration during meals. So we have to assess for swallowing. Evaluation should be done by the speech language pathologist, confirming that patient's type of consistency of food and liquid form. What can they swallow safely? Take the thin liquids or should be thickened? What consistency is that? Honey thick or puree thick? So all these details should be done by the speech language pathologist, and they determine the extent of the problem, the swallowing issue, and then the consistency of the food and liquid form, if that's thin liquid or should be thickened liquids. Don't always assume that all patients with MG should be on thickened liquids, or patients with stroke, who have developed stroke, they should be on thickened liquids. It depends on the scenario, on the given problem or given client, and it depends on if there is any more hints or indications about the swallowing problem, the extent of the problem. And you don't assume that all patients with stroke or Parkinson's or MG or MS, they always have swallowing. They may have that swallowing difficulty, but not to the point that or extent that they should always be on thickened liquids. It should be determined based on the SLP's, speech language pathologists' swallow eval results and the recommendations provided by the or from that swallow evaluation test. Trigeminal neuralgia and Bell's palsy. So the assessment of trigeminal neuralgia attacks, including the triggering factors, characteristics, the symptoms, manifestations, pain management techniques. So the painful episodes are usually initiated by the triggering mechanism. And I think we have questions, right, in class discussions or questions. We went over this triggering mechanism of like continuous stimulation of specific point, like triggering zone, along the distribution of the the branches, the nerve branches, or the branches of the nerve of the trigeminal nerve, which has like 3 branches, and the stimuli that may precipitate the pain, like chewing, toothbrushing, cold or hot air, that like air draft, either cold or hot, that always going to trigger that trigger zone or trigger zone facial of the trigeminal nerve. So oral hygiene is going to be some extent neglected in patients with trigeminal neuralgia because they're trying or attempt to avoid and trying to evade from this pain episodes of experiencing pain. So that will be neglected in patients with trigeminal neuralgia, the oral hygiene, because they are fear of triggering the facial pain, and that may lead to like a gingival disease, like gum disease. May have also dental cavities or abscesses. Bell's palsy, it can cause paralysis of the eyelid and the loss of the blink reflex on the affected side of the face. So the eye may not, so patient unable to close the eye, or like unable to completely close the eye. They cannot front the forehead. They cannot blink, and these problems, they render the eye susceptible to the main. I think one of the main concepts here about nursing care of patients with Bell's palsy, about the inability of the patient to close their eyes, or I mean the affected eye. So in which that would eventually lead to the dryness of the cornea. Corneal dryness, very dangerous. It's inevitable. I mean, it's kind of can lead to a corneal damage, and that's very dangerous. So these problems, because they render the eye susceptible to drying and irritation, either from dryness from air, continuous air, touching, unable to, because of the inability to close the eye, either from the dust, from debris, all that can lead to that dryness of the cornea. So we have to make sure that patient is able to close it with like cover it with the eye cover, and to be protected from dryness or from drying and subsequent ulceration or abrasion. So the cornea must be protected from drying and subsequent ulceration and abrasion. And teaching the patient to manually close the eyelid and like at intervals, and to sometimes they will also be we'll teach them how to instill some of the artificial tears during the day, so that will protect the eye from the corneal dryness. And these are the medications that I would recommend that you go over these meds. Some of them medications, and others will be classes like CHEI, like the prostigmine or pyridostigmine for MG. For example, this one is class of medications, and these would be provided to patients with suspected or with who had developed the myasthenic crises. So that said, that concludes our session. Any questions?
Professor, when will this recording be posted?
We'll try my best to do it tonight, if not tomorrow morning.
Okay, thank you.
Yo.
Professor, are we gonna have math question, like how many if?
Oh, yes. Thank you very much. 2 questions, 2 math questions. One, sorry. Yeah, one about the fluid replacement for patients with burn injuries. And another math question
Burn, well, the burn one was on exam 3.
Oh, sorry, that would be exam 3. Sorry, math questions. Yeah. So, yeah, burn injury exam 3. So the math questions will be just regular math questions. Just regular math questions that you used to have in like Adult 2 and other courses.
Okay, thank you.
So keep practicing the math. To practice the math. Other questions?
No,
Others?
thank you, Dr. Mikky.
All right. Thank you very much.
Thank
Take care.
you.
Thanks.
Thank
Take
you,
care.
Professor.
Bye-bye.
Enjoy
Take
your
care.
weekend.
Professor.
You take
Good
care.
night.
Nice weekend, everyone.